Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at 6 exam questions in one clinical course. This is Season 1, Episode 5. The cycle begins again. And today we're going to be looking at internal medicine. If you haven't yet subscribed to the channel, please subscribe to the channel, drop a like, drop a comment in the comment below, and share the link to an individual or a friend for the YouTube algorithm, of course, and of course to help out your buddies out there. Grab your piece of paper, grab your pen, and let's go. Apologies for the voice. I think I'm having a cold. So beginning with our question 1. A 60-year-old man presents to the emergency department due to substernal chest pain. He describes the pain as crushing and it radiates down the left arm. Medical history is significant for hypertension, hypercholesterolemia. On physical examination, the patient is diaphoretic. An ECG demonstrates ST segment elevation and cardiac troponins are significantly elevated. The appropriate acute therapy, the coronary catheterization lab is activated and cardiology is consulted. And the questions are as follows. What is the diagnosis? What risk factors are associated with this diagnosis? Give the pathophysiology of your diagnosis. Outline the acute management of this patient. So I'll give you a second to think through the question. So this is a man that's 60 years old. First of all, has come in with a characteristic type of chest pain. Remember that when you get chest pain that is crushing in nature and often radiating to the left side of the arm, you should think that there could be a problem with the heart. This person has risk factors for heart disease. They have hypertension, they have hypercholesterolemia, and their age is above 60 years old. Or rather, they are 60 years old. And when you do an ECG, it shows that there is an abnormality on the ECG, which is an ST segment elevation. So obviously, your diagnosis would be that this person has an acute coronary syndrome. To be specific, an ST segment elevation myocardial infarction in a known hypertensive patient. What risk factors are associated with this diagnosis? So their age of this individual is 60 years. The gender of this individual, it's much more common in males than it is in females. But of course, postmenopausal, the incidence is almost equal, because the hormones are no longer there to be protective to the female. Then hypertension is a risk factor for developing myocardial infarction, the STEMIs, and hypercholesterolemia is also an indication, or rather a risk factor for developing myocardial infarction. If they gave you a history of smoking, then you would include smoking as also another significant risk factor. So is diabetes mellitus, but they haven't yet given us that in this specific question. Give the pathophysiology of your diagnosis. So remember that in myocardial infarction, there is an imbalance between the myocardial oxygen supply and the demand. And this is often due to either narrowing or blockage of the coronary vasculature, and this blockage is caused by an atheromatous plaque. So initially at rest, the perfusion to the distal segments or the distal parts distal to this lesion is decreased. But however, there is some vasodilatation of the coronary arterioles, and this helps to maintain adequate blood flow to this area, preventing ischemia. But then when this atheromatous plaque or the narrowing progresses to a point where it's actually beyond 70% obstruction, or during exertion where this person's myocardium requires more oxygen, then this oxygen demand is increased and it can no longer be met by the perfusion or the supply that's there from the coronary vasculature. Therefore, now there's going to be some ischemia that's going to be taking place, and the heart muscle is going to begin to die, and you get these characteristic symptoms that we see in myocardial infarction. And remember, if these symptoms are lasting longer than 15 minutes, then this person is having a myocardial infarction. Outline the acute management of this patient. So you want to admit this patient, you reassure this patient, and you keep them calm and make them as comfortable as possible. You give them oxygen via a face mask. You secure an IV line. You could give them aspirin, about 160 to about 325 milligrams tablets, to prevent any further platelet aggregation. If you have clopidogrel, you could give a loading dose of that. Then if the patient is tachycardic or they are hypertensive, you could give beta blockers intravenously. Treat the pain using your morphine 2 to 4 milligrams IV every 5 minutes. Give nitroglycerin, which are nitrates. You could give these sublingually up to 3 times of doses of 0.4. You can give them at 5-minute intervals for up to 3 doses. You could also use anticoagulation. So if you're using unfractionated heparin, you preferably want to use this for patients that are going for immediate or even early angiography. If the patient is not going for this, and angiography is actually not really planned, you could use low molecular weight heparin, for example, enoxaparin. So remember the mnemonic for management of myocardial infarction, MONA. M for morphine, O for oxygen, N for nitrates, and A for aspirin. And then, of course, you could perform reperfusion using the percutaneous coronary intervention, the PCI, where you use a balloon and you stent. Then this is usually done if the patient presents within 12 hours of the STEMI, and they haven't yet given us the time here of when this patient presented. And if you do not have PCI, you could also consider using thrombolytic agents like alteplase, but we do not do that in our setting. You could alternatively perform angiography plus or minus revascularization within 48 hours, and the revascularization is usually either PCI or a coronary artery bypass, which is usually like the definitive, more of a long-term management. So question 2. Mr. Tembo, male 56, has just been admitted from the hematology clinic with generalized body weakness, sore tongue, progressive worsening confusion, and paresthesia of the upper and lower limbs. He has been admitted to hospital 4 times now. He has received 12 blood transfusions in the previous admissions. In his last admission, his doctors had indicated that he needed to do further investigations, but were not able to do so due to lack of finances. On physical examination, he appears very pale, wasted, and confused. Both his lower limbs were hyporeflexic. Urgent full blood count was done and revealed the following. So white blood cells was 3.2 times 10 to the power 9 cells per liter. RBCs were 1.6 times 10 to the power 9 cells. Hemoglobin was 4.8 grams per deciliter. Hematocrit was 14.4. MCV was 126.8. MCH was 48.2. MCHC was 33.2. Platelets were 54. And reticulocyte count was 0.12. Peripheral blood smear showed hypersegmented neutrophils. What a mouthful of a question. So part A, list 4 abnormalities on the hemogram. So as we can already see, the white blood cells is marginally low because the normal count is 4,000 to about 11,000. RBCs are low, hemoglobin is low, hematocrit is low, MCV is high, MCH is high, platelets are low, and of course it's abnormal to see the hypersegmented neutrophils on the peripheral smear, but that's not part of the hemogram. So what is your diagnosis? So this patient is coming to you with features of confusion. They have paresthesia of the upper limb and the paresthesia of the lower limb. And they have a macrocytic type of picture when you look at their hemogram. And what gives you the diagnosis, or what clinches the diagnosis, are the hypersegmented neutrophils. So these hypersegmented neutrophils are more or less pointing you towards this person having a vitamin B12 deficiency. And remember that vitamin B12 deficiency is needed for synthesis of DNA as well as functioning of the nervous system. So this person could have subacute combined degeneration of the spinal cord with macrocytic anemia, most likely secondary to vitamin B12 deficiency. That's where you get the 3 marks. List 4 conditions that cause this blood picture. So it could be caused by vitamin B12 deficiency. It could be caused by folate deficiency. Pernicious anemia, which is an autoimmune condition where you have autoantibodies that are produced against parietal cells, and they prevent the synthesis of intrinsic acid, or damage or reduce the synthesis of intrinsic acid, or intrinsic factor rather, and this intrinsic factor can no longer be absorbed together with vitamin B12, or rather vitamin B12 is not really absorbed efficiently in the absence of intrinsic factor. Gastrectomy has also a similar effect. Then list 5 important signs you might elicit on physical examination. So you may see atrophic glossitis, which is a beefy red tongue. You may see decreased sensations in the lower limbs. Sometimes you may even see an abnormal balance because these people have abnormalities in the kinesthetic sensation. They have abnormalities in their balance and proprioception. Then you may get reduced power in the limbs. There may be cold extremities. There may be a hollow systolic murmur or pansystolic murmur or hemic murmur that you may see. You may get a rapid pulse, and there may be cold extremities. What is your immediate management? So you want to admit this patient, you want to cross-match this patient, transfuse packed cells. If you transfuse whole blood, you may tip this person into heart failure. And then, of course, you may also transfuse fresh frozen plasma or platelets if you have, and cover this individual on antibiotics. Investigate the underlying cause. If the cause is due to vitamin B12, give this person vitamin B12 supplements. Question 3. A 50-year-old man with cirrhosis is brought to the emergency room for altered mental state. He lives at home with his mother who noted that he was slow in his responses and disoriented. He has a history of alcoholic cirrhosis, and for the past week, he has not eaten much food. His last drink was 10 days ago. He experienced a bout of diarrhea and vomiting. On physical exam, he is noted to be jaundiced with asterexis, his mucous membranes are dry, and his capillary refill is delayed. Question A, what is the diagnosis? So this patient obviously has hepatic encephalopathy secondary to alcoholic-induced liver cirrhosis. And what are the possible precipitants of your diagnosis in this patient? So if we look at this patient, the first thing that's there is that this patient is an alcoholic. So they could have taken alcohol. Alcohol could trigger someone going into hepatic encephalopathy. Number 2, this person isn't eating so much. So hypoglycemia can trigger this person to go into the hepatic encephalopathy. And on top of that, they are having vomiting and diarrhea. So dehydration can cause this person to go into hepatic encephalopathy. Electrolyte imbalances that could be caused by the diarrhea and the vomiting can cause this person to go into hepatic encephalopathy. And of course, infections that he could have picked up. Then give the grading of your diagnosis, or rather, what is the pathogenesis of your diagnosis? So there are many theories that have been stipulated, but the most commonly studied theory is known as the ammonia theory. So remember that ammonia is going to be produced by intestinal bacteria and breaking down of proteins. So ammonia is going to be absorbed by these astrocytes and is converted to glutamine. And then the glutamine is going to increase the intracellular osmotic pressure, meaning that it's going to draw more water into these astrocytes and cause swelling and cerebral edema. In addition to this, what we've seen in patients with hepatic encephalopathy is that sometimes there could be increased blood levels of aromatic amino acids such as tyrosine and phenylalanine. There's also reduced branched amino acids such as valine, leucine, as well as isoleucine. And in addition to this, there may be some accumulation of false neurotransmitters or activation of gamma-aminobutyric acid, which is GABA inhibitory neural systems. But of course, the ammonium theory is the one that has been well studied and accepted. Question D, give the grading of your diagnosis. So this person is at grade 2. So let me just give you a list of things that you find in the different grades. So hepatic encephalopathy is graded into 4 grades. So in grade 1, the following features are seen. You may sometimes have a mild altered mental state, which is what we see in this patient. There may be some apathy. There may be restlessness. There may be reversal of sleep. There may be slowed intellect. There may be impaired computing abilities. There may be impaired handwriting. Then in grade 2, where this patient is, they may be disoriented. This person is disoriented. There may be some drowsiness or lethargy. There may be asterexis, which this person does have. And then stage 3, there is stupor, where they are barely arousable. There are signs of upper motor neuron lesions like hyperreflexia, extensor plantar responses, even increase in tone. And of course, stage 4, there is coma, or rather grade 4. Then question E, list 2 drugs used in the management along with their mechanism of action. So we could use rifaximin. So rifaximin just pretty much reduces the colonic bacteria that generate ammonia. Additionally, we may use lactulose. So lactulose acts as an osmotic purgative that is obviously going to reduce the colonic pH and limit the absorption of ammonia. Additionally, lactulose can be also given, and it's going to be metabolized by colonic bacteria, and it's actually more efficient than lactulose. Then lactose is given to patients who have a deficiency with lactase. Now, whichever one you give, whether you're giving lactulose, whether you're giving lactulose, whether you're giving lactose, they're all going to be fermented by the bacteria inside the gut, into organic acids, and these organic acids are going to reduce the pH of the stool. And remember that once the pH has been reduced, you increase the concentration of the hydrogen ions, and these hydrogen ions are going to bind to ammonia, which is NH3, to form ammonium, which is NH4. And the ammonium, which is NH4, has a very difficult time diffusing across the membrane and back into the bloodstream. Thereby, this is going to be excreted in the stool. And in addition to this, these drugs have a laxative effect, so they result in also excretion of ammonia. Moving on to question 4, a 33-year-old man is brought into the emergency department with fever, lethargy, and confusion. He is cachectic, in acute distress, unable to respond to questions or follow commands. His friend confides that the patient has been sexually active with multiple partners and was diagnosed with HIV several months ago, but was lost to follow-up. Based on prior records, his most recent CD4 count was 65 cells per microliter. Give the possible differential diagnosis for this patient. So this is a patient that's HIV positive, have a very low CD4 count of 64 cells per microliter of blood. Then they have multiple sexual partners. Obviously, if they have contracted HIV, they obviously may have contracted these other sexually transmitted infections. So this person, first of all, could have HIV encephalopathy. It may present in a similar way. They may have cryptococcal meningitis, which is by far one of the most common causes of meningitis in HIV patients. This patient could also have TB meningitis. They could have neurosyphilis because they could have contracted this STI, which wasn't really treated for a while and progressed from primary, secondary to tertiary or neurosyphilis. Then they may also have progressive multifocal leukoencephalopathy. They may have CNS toxoplasmosis, though they're not really showing any signs of focal neurological deficit. Same thing with neurocysticercosis. Then part B, HIV is classified as a single-stranded positive sense RNA retrovirus. What is a retrovirus? So this is just simply a type of virus that's going to use reverse transcriptase enzyme to translate its RNA genome into DNA genome. And this DNA genome can be integrated into the host cell. The above patient was treated for meningoencephalitis and subsequently commenced on antiretroviral therapy. At one of his reviews 2 years later, he presented with signs of opportunistic infection. You decide to do CD4 and viral load and note that the CD4 is below 200 cells and his viral load is 2 million copies per mil. You decide to do resistance testing. So define resistance testing and what it involves. So remember that resistance testing is... Or rather, I skipped the question. Name the retrovirus that causes disease in humans other than HIV. So you have what is known as human T-cell lymphotropic virus, or you can call it human T-cell leukemic virus. So with resistance testing, you're just simply testing that's going to be done in order to determine whether a patient that has HIV has a mutated form of the virus that doesn't respond to antiretroviral treatment. So there are two types of tests that can be done. There's what is known as genotypic resistance testing and what is known as phenotypic resistance testing. So with genotypic resistance testing, what you do is that you're going to examine the genetic structure or the genome or the genotype of the patient's HIV strain. So a blood sample is gotten from the patient and then the HIV is analyzed for the presence of specific mutations that are known to make the HIV virus resistant to certain drugs. Like for example, if you get a mutation M184V in the reverse transcriptase gene, then this virus is obviously going to be resistant to drugs like lamivudine. It's going to be resistant to drugs like emtricitabine. Then phenotypic testing is where you actually directly measure the sensitivity or the phenotype of the patient's HIV in response to specific antiretrovirals. So you expose the virus to certain antiretrovirals and you see how it reacts. And then in genotype, you actually study the virus. Then list 5 groups of antiretrovirals and one example under each. So they are nucleoside reverse transcriptase inhibitors, things like zidovudine, lamivudine, stavudine, tenofovir, abacavir, and emtricitabine. Then non-nucleoside reverse transcriptase inhibitors such as efavirenz and nevirapine. Remember that nucleoside reverse transcriptase inhibitor, the major side effect of these drugs is that they cause bone marrow suppression. Then the non-nucleoside reverse transcriptase inhibitors, these are pretty much going to be causing patients to undergo some insomnia. They may have some nightmares. They may even have psychosis. Then with the protease inhibitors, you have drugs like lopinavir, ritonavir, and indinavir. You could also have saquinavir, which are going to be causing maldistribution of the fat. So they may develop what is known as an interscapular fat pad. We no longer want to call it a buffalo hump, refer to it as an interscapular fat pad. Then you may also have fusion stroke entry inhibitors, things like enfuvirtide and maraviroc. These usually just tend to cause some GI discomfort. You may also have integrase inhibitors such as dolutegravir and raltegravir, which are also going to be causing some GI discomfort. Moving on to question 5. A 35-year-old patient presents to Levi Mwanawasa General Hospital with arthritis of the small joints in the hands and a seizure disorder. She has a history of being unwell for 3 months now and has had some episodes of irrelevant talking during this period. 2 weeks ago, she noticed some eruptions on her cheek, which have persisted until now. Her past medical history is significant for anemia and history of miscarriages. On admission, you decide to do urinalysis, which showed the following parameters: proteins 3+, blood 2+, glucose nil, specific gravity 1.015. What is the most likely diagnosis? So I actually want you to think through this question before I tell you the answer. I'll give you 4 seconds. So this patient is presenting to you with features of arthritis, a seizure, and they have an eruption on their cheek. So it looks like they also have anemia and history of miscarriages. So it looks like there's a multisystemic problem that's happening here. And one condition that ties almost all these symptoms together is an autoimmune condition that's referred to as systemic lupus erythematosus, or SLE. So mention 5 clinical features you would look for. So there are skin features. You could have malar rash. You could have a discoid rash. You could have Raynaud's phenomenon. You have serositis, which is pretty much pleurisy and pericarditis that may cause shortness of breath and chest pains. You may have mouth and facial features such as painless oral ulcers, painless nasal ulcers, as well as non-scarring alopecia, which is hair loss. Then part C, what could the rash on her cheek be? So this is obviously malar rash. List 3 diagnostic investigations you would request for. So you'd request for antinucleic antibodies, ANA. You would request for double-stranded antibodies. You could request for anti-Smith antibodies. And if you want, you may do a renal biopsy. Then what is the most likely renal complication in this patient? So this patient obviously has lupus nephritis. Question 6 and the final question. If you still haven't yet subscribed, what are you waiting for? Hit the subscribe button, hit the like button to help me out with this dark algorithm that's there on YouTube. So, question 6. Jane, a 35-year-old teetotal, never taken alcohol before, was commenced on antiretroviral therapy, heart, a year ago. She presents to admission ward complaining of severe body weakness, headache, palpitation. On examination, she is found to be febrile to touch, very pale. What pointers in the history would help you elicit the cause of the anemia in this 35-year-old HIV patient on heart? So the first thing that should come to your mind is, what type of drugs is she taking? Because remember I told you the nucleoside reverse transcriptase inhibitors have a side effect of bone marrow suppression. So could it be that this drug is causing the bone marrow suppression? So you ask about the type of regimen she's taking. You ask about the compliancy of the drug, because sometimes she couldn't be taking the drugs and she could have these other infections that could be setting in, causing anemia of chronic disease. You ask for the diet of an individual. If they are taking enough proteins, they could be wasted. And if they're not taking enough proteins, they're not taking enough iron or the raw materials needed for RBC synthesis, they obviously could go into anemia. You ask about the menstrual details, so the last menstrual period, if it was regular, if there was any menorrhagia that may be there. You also ask about the obstetric history, the number of pregnancies that she has had, and the modes of delivery that she has undertaken, if at all she has. Then you ask for presence of chronic illnesses if she has been found with conditions such as tuberculosis. You ask for a history of her taking alcohol. You ask if she's bleeding from anywhere in the nose, in the mouth, underneath the skin, which may indicate that this woman could have even a pancytopenia that may be there. You ask for a history of blood in the urine or blood in the stool. Then what features on physical examination would help in identifying the underlying cause of anemia? So you could look for koilonychia, which will point you towards iron deficiency. You could look for angular stomatitis, which will point you towards iron deficiency. You could look for atrophic glossitis, which will point you towards vitamin B12 deficiency. You could look for paresthesia, even reduced power, reduced sensations, abnormal balance, ataxia, which are going to be pointing you towards vitamin B12 deficiency. Then further examination of Jane reveals that she has massive splenomegaly. List 5 differentials. So the 5 differentials for massive splenomegaly, just remember the mnemonic: China, mobile phones suck. So China, MPS. China mobile phones suck. C for chronic myeloid or chronic lymphoid leukemia. H for hairy cell leukemia. I for infections such as malaria, EBV, CMV. N for neoplasms such as lymphomas. A for autoimmune conditions such as autoimmune hemolytic anemia. M for myelofibrosis with myeloid metaplasia. P for polycythemia vera. And S for sarcoidosis. So a blood count shows the following: RBC 2.4, HB3, hematocrit 18, MCV 110. A blood film shows macrocytic anemia with a megaloblastic picture on bone marrow. So whenever you see this, you should think that this woman could be maybe pregnant, maybe have a liver problem, or maybe could be alcoholic. So they should rule those things out. So she had a normal liver function test, which they have ruled out. Transaminase are within normal range, so it means that has been ruled out. Gravindex is positive, so she's not pregnant. So what are the most likely causes of anemia with the above results in mind? So it could be that this woman has vitamin B12 deficiency. She could have folate deficiency. She could have malabsorptive syndromes, because HIV also causes a type of enteropathy that may affect the absorption from the gut. Thank you for spending your time to listen to this video on MK's exam secrets. Stay tuned for the next episodes. We may release 2 episodes in a day, so please stay peeled on the channel. Share the channel if you haven't. Tag a friend. Subscribe to the channel. Like the video. Drop a comment. Until next time, my name is Dr.